Hi friends, I am Dr. Pratap Singh Rathod. I have done MD in Pharmacy Medicine. In today's video, we will continue with sedative poisons. In that, we will discuss about poisoning from barbiturates. Barbiturates are usually prescribed drugs. They are available as white crystalline odorless powders with faintly bitter taste. They have a depressant action and on central nervous system, and large doses directly depresses the medullary respiratory centers. Coming to classification of barbiturates are classified into based on how the mechanism of action. Long acting, where the onset of action is 2 hours and they last for 6 to 12 hours. Example include barbitone, phenobarbital, methaphenobarbital, diazobarbic acid, methylbarbital, phenytoin. Intermittent acting, where the onset of action is half to 1 hour and duration of action is 3 to 6 hours. Examples includes amobarbitone, beta-barbital, probarbital, sodium amytal, eprobarbital, vinabarbital, alabarbital. Short-acting barbiturates includes duration with action less than 3 hours. Examples include cyclobarbital, phenobarbital, seconal, orter amobarbital, cyclobarbitone, quinabarbital. Then ultra-short acting, which acts immediately, or duration of action is about which lasts for 5 to 10 minutes. Examples include pentothal sodium, kementhol sodium, and thiamethyl sodium. So all these are barbiturates with different duration of action. Coming to absorption, they are rapidly absorbed from gastrointestinal tract, including the rectum and from subsequent tissue. They are distributed evenly. They are concentrated in the liver by for short time and then evenly distributed in the body fluids. They are partially destroyed in liver and excreted in urine. Even in irreversible brain damage, they are completely metabolized or excreted before death. So if the person survives after consumption of barbiturates, even after death also, within few hours also it gets eliminated, excreted. Coming to signs and symptoms, acute poisoning results from single large doses or with repeated small doses. Usually there is a drowsiness, confusion, excitement, delirium, hallucination, which is common. Later on there is ataxia, vertigo, slurred speech, headache, paresthesia, subjective visual disturbances occurs. Later on stupor progressing to coma, loss of reflexes, loss of response to painful stimuli. Next, there is respiration may become rapid or shallow, may have slow or labored, but minute volume is always reduced. There is falling cardiac output leading to cardiovascular collapse, evidenced by cyanosis, hypotension, weak rapid pulse, and cold clammy skin. The pupils are usually slightly contracted but react to light. They may dilate during terminal asphyxia. Decreased peristalsis may occur in deeply comatose patient. Urine may be scanty or suppressed or may contain sugar, albumin, and hematoporphyrin. There is incontinence of urine and feces may occur. The body temperature usually reduced. Fever indicates the person may have infection of bronchopneumonia. Respiration becomes irregular. Sometimes there may be Chinese stroke breathing. Chinese stroke breathing is rapid inhalation and small shallow breathing. There is delirium, hallucinations, ataxia, paresthesia, loss of reflexes, hypotension, cyanosis, stupor, progression to coma. Sometimes there is blister formation occurs, which is commonly seen in barbiturates, often in the area of erythema, strongly suggestive of barbiturate poisoning. Rupture of blisters leads to red raw surface, which later on dries and leads to brown parchment-like area. They are commonly found in sites where the pressure has been exerted between two skin surfaces, such as interdigital clefts, inner surface of knees, buttocks, backs of thighs, calves, and forearms. Blisters occur in about 6% cases, and are believed to be due to direct toxic action on the epidermis leading to blisters. The coma may contribute to a few hours to few days, and the patient then makes gradually recovery. During recovery, there may be nystagmus, diplopia, and temporary failure of accommodation may occur. Death occurs where respiratory failure, ventricular fibrillation, and bronchopneumonia if there is infection. There is also irreversible anoxia and pulmonary edema also may be seen in later stages. Phenytoin causes gingival hyperplasia in chronic therapy. Some overdoses of phenobarbital can cause unconscious for a prolonged period of time. Severe shock or respiratory failure are more common and more serious in medium or short-acting barbiturates. Specifically, phenytoin causes gingival hyperplasia. Phenobarbital can cause unconsciousness, and medium and short-acting barbiturates can cause respiratory failure. Coming to fetal dose, short-acting barbiturates 1 to 2 grams, medium-acting 2 to 3 grams, long-acting 3 to 5 grams. Lethal dose includes for long-acting 10 mg to 100 mg, medium-acting 7 mg to 100 per ml, short-acting 3 to 3 mg per 100 ml is lethal blood levels. When they reach, the person usually dies. Fetal period is 1 to 2 days. Treatment: gastric lavage to remove the poisons. Barbiturates are usually available as tablets consumed in form of tablets, so it should be removed with warm water mixed with potassium permanganate and suspension of activated charcoal or tannic acid, and magnesium sulfate are also used for purgation. So usually gastric lavage is done with potassium permanganate to remove the unobserved poison, and is also sometimes magnesium sulfate is added to remove the poison in the form of purgation. There is no specific antidote for barbiturates. Another therapy, that is giving stimulants like caffeine, amphetamines, is usually avoided unless clear indication is indicated. Scandinavian method is one form which uses measurements like anti-shock measures, maintenance of patent airway, and adequate respiratory support is sometimes can be followed. Normal saline with 5% glucose IV increases the rate of excretion of barbiturates. Artificial respiration and oxygen is given if required. Patient should be kept warm and mucus should be removed from the throat repeatedly, either by raising the foot or by aspiration to keep the airway patent. Bowel should be evacuated by enema. Noradrenaline is mainly for recovering from shock and low blood pressure. Hemodialysis and extended transfusion are sometimes life-saving measures. Charcoal can also be charcoal hemopropionation is given to remove the poison from the blood. Forced alkaline diuresis is sometimes most useful method for barbiturate poisoning. It is useful in poisoning by barbiturate which are not protein bound like phenobarbital, allobarbital, and barbital. Except for these three barbiturates, phenobarbital, allobarbital, barbital. For others barbiturates, alkaline diuresis is helpful. Forced alkaline diuresis is brought about by mannitol 100 to 200 ml of 25% solution, followed by an infusion of 500 ml 5% solution during next 3 hours. By this, the urine concentration becomes alkaline in nature, and barbiturates can be easily excreted in the urine. For deep bone thrombosis and thromboembolism in patients with prolonged coma, mini heparization, elastic stockings, and inflated cups are useful. This is done only in cases of person who has gone in coma for longer duration. There is chances that DVT can occur. For them, heparization is done. Antibiotics is given to minimize the risk of pneumonia. Again, cases of the person is gone for coma or respiratory depression. In these cases, there is chance of the person may have pneumonia. Antibiotics treatment given, and symptom treatment is given as any new symptoms occurs. Coming to postmortem appearance, they are not characteristics of barbiturates, but mainly because of asphyxial signs. Cyanosis is present. A quantity of white particles may be ingested. Barbiturates may be seen in the stomach. Gastric mucosa may be congested. Fundus may be thickened, granular, or hemorrhagic. Cardiac and lower esophagus may be eroded from regurgitation. Hemorrhagic blistering and hemorrhagic necrosis of the gastric mucosa may be seen. Lungs are congested, edematous, and almost become black in color. Petechial hemorrhages may be present in the lungs and on the pleura and pericardium. The whole venous system is engorged with dark deoxygenated blood. Kidneys show degenerations and converted tubules. Other organs are also congested. Necrosis is seen in corpus callosum, focal areas of cerebrum and cerebellum. Putrefaction can cause significant decrease in blood barbiturate levels. Coming to chronic poisoning. Chronic poisoning mainly occurs because of chronic consumption of barbiturate tablets. Tolerance usually develops rapidly and usually marked. There is also cross tolerance with alcohol. When combined with alcohol, tolerance increases. It occurs when barbiturates are used therapeutically in epilepsy and psychoneurotic patients. The signs and symptoms resemble those of chronic alcoholism, and progressive impairment of cerebral functions, dysarthria, and ataxia and depressions are seen. Tendon reflexes may be depressed, or there may be hypertonia and tremors, lack of Parkinson type. Addiction is a serious problem in barbiturates. Dependency is both psychic and physical. The person who gets addicted by barbiturates usually becomes physically addicted as well as psychically, even though he may not be may have withdrawal, but even then the person gets psychically addicted to barbiturates. The impairment of mood, behavior, and intellectual functions can cause social deterioration in chronic poisoning of barbiturates. Withdrawal symptoms occur within a day or may persist for 2 weeks. Common features of withdrawal includes anxiety, nausea, vomiting, weakness, hypertension, tremors, and disturbance of vision. Convulsions may also occur. Coming to circumstances of poisoning, barbiturates are commonly used for committing suicide. They take large doses of more tablets of barbiturates and commit suicide. Due to requirement large size of fatal dose, prolonged unconsciousness, they are rarely used for homicidal purposes. Accidental poisoning may result due to automatism. Automatism, also known as barbiturate automatism, is a form of committing suicide by taking large doses of barbiturates. Coming to methaqualone, this is also one form of drug sedatives. It is sold as name of Mandrax or Melcinin, which consists of methaqualone as for treated for insomnia patients. So usually insomnia, methaqualone is prescribed. Some persons are extremely sensitive to these drugs and may become unconscious even after just one tablet. It is taken some hours after food and patient may feel dizzy. If the person consumes methaqualone and feels dizzy and a symptom similar to hypoglycemia is produced. 2.5 grams of drug produces unconsciousness within 2 hours. Within half an hour, sometimes drug can produce unconsciousness. In modest doses, drug produces euphoric state and inhibitions disappears. There is excitation, delirium, extrapyramidal signs, there is hypertonicity, hyperreflexia, and myoclonus, and convulsions occurs. There may be muscular twitchings, extensive plantar response, carpopedal spasms, paresthesia, tachycardia, cardiac arrhythmias, pericarditis, myocardial infarctions, hypotension, hypothermia, hypoproteinemia, and gastric bleeding can occur. Addiction may occur and some degree of tolerance is seen after prolonged usage when treated for insomnia. Excretion is mainly in the urine. 5 grams is the fatal dose of methaqualone. Treatment, stomach wash and symptomatic treatment is given. Next, a sedative is the chloral hydrate. This is given, it is also known as dry wine. It is a colorless crystalline substance having peculiar pungent odor and a pungent bitter taste. In its principal action is the depression of central nervous system. It is absorbed rapidly from stomach and small intestine and also from the rectum. It is metabolized rapidly in liver, mainly to trichloroethanol, which is also a hypnotic. Trichloroethanol is conjugated with glycolic acid and excreted in the urine. Coming to signs and symptoms, they resemble those of barbiturates, but in addition to them, there is retrosternal burning sensation, vomiting, and rarely jaundice. Albuminuria may also be found due to renal damage. Signs symptoms, heterorenal damage may occur. Death usually occurs from paralysis of respiratory centers. In few cases, death may occur from failure of the heart soon after swallowing the drug. 5 to 10 grams of chloride is fatal. 8 to 12 hours is the fatal period. Stomach wash is the treatment with alkaline solution. Forced dialysis and dialysis by mannitol can be given. Flumbazanil 0.1 mg and infusion to a total of 3 mg produces marked improvement. Symptomatic treatment is given for any other additional symptoms. Postnasal appearance, gastric mucosa softened, reddened and eroded and smells of chlorohydrate. Brains and lungs are congested. Hepatorenal damage is seen in sometimes. Chronic poisoning of chlorohydrate, it occurs after prolonged therapeutic usage. Symptoms are those of gastrointestinal irritation with erythematous and electrical eruptions of the skin, tremors and dyspnea. Convulsions, mental degenerations and liver damage may also occur. Habitual use can lead to tolerance and physical dependency and delirium when drug is withdrawn. Circumstances of poisoning of chlorohydrate, accidental poison results from taking large doses. Suicidal cases are rare. It is given in food or drink to render a person suddenly helpless for purpose of robbery and rape. It is also sometimes used as a knockout drops. Its action is so rapid in such conditions that it has been given the name of knockout drops. A combination of alcohol and chlorohydrate is commonly known as mikifin. It is often added to liquor to increase its potency and overdoses can lead to death. Next sedative includes the bromides. Potassium sodium bromides are in constant use in medicines. Up to 10% patients exhibit intolerance. Signs and symptoms, there may be nausea, colicky, vomiting due to local action, followed by vertigo, staggering gait, mental confusions, fall of blood pressure, feeble pulse, subnormal temperature, shallow respiration, muscular weakness or paralysis, collapse, stupor, coma. There may be irritation, edema of the mucous membrane. The bromide displaces chlorides from plasma and cells and cause fatal depression of nervous system. Excessive consumption may lead to clinical picture resembling that of intoxication. Fatal dose is 30 to 45 grams per 50 mg per ml of in the blood concentration. If it reaches, it is toxic. Fatal period is 6 to 18 hours or more. Treatment: gastric lavage, then chloride. Any form of chloride is useful, is useful to eliminate the bromides, and as such, normal saline IV by drip method or 2 grams of sodium chloride in capsules every 4 hours by mouth are useful. So chloride and bromide get exchanged in the bloodstream for an removed. Hemodialysis in severe case of poisoning, and C2020 is given. Postmortem appearance are not characteristics, and usually not any specific changes is seen. Circumstances of chronic poisoning of bromide: it results from continued ingestion of bromides. There is a blunting of memory, muscular weakness, incoordination, skin rashes, and there may be delusions and hallucinations may be present. In over 30% of cases, chronic bromide ingestion, bromide rash develops. It begins of acneiform eruptions on the face and may spread to the whole body. Coming to circumstance of poisoning: acute fatal poisoning is rare and is likely to occur only in case of when the person tried to commit suicide. Poisoning is usually accidental. Next is the paraldehyde. It is also again given as sedative. It is a clear colorless liquid with an unpleasant ethereal odor and acrid nauseous taste. It is used as a hypnotic by mouth, rectum or palatal and has a basal anesthetic. So it is used as a hypnotic. Fetal poisoning by paraldehyde is uncommon. When ingested, there is nausea, vomiting, erections, headache, giddiness, and breath smells of paraldehyde. Drowsiness sets in, pulse becomes shallow and feeble, shallow breathing, dilated pupils, cyanosis, subnormal temperature, and coma, and death may occur from respiratory failure. Pulmonary edema and bronchopneumonia are also common. Fetal dose is 25 to 50 ml orally and 10 to 12 ml parenterally is fetal. Fetal period is within few hours. Gastric lavage solution of sodium bicarbonate to be continued until washing ceases to smell of the drug. Activated with charcoal is also useful. High colonic irrigation to eliminate the poison. Calcium gluconate and dextrose intravenously. Artificial respiration and oxygen inhalation if oxygen saturation decreases, and symptom treatment is given. Postmortem appearance: body smells of paraldehyde. Typical smell of paraldehyde is present. Mucosa of stomach is hyperemic and may be slightly inflamed. The viscera are congested because of asphyxia, and asphyxia signs are seen, and there is congestion. Pulmonary edema and bronchopneumonia are also usually seen. Chronic poisoning from bromides: usually symptoms are similar to those in chronic alcoholism, such as gastric irritation, muscular weakness, and tremors of the hands and tongues. Hallucinations and delusions may also be present. Poison is usually accidental in nature. As such, suicide is rare. It is less common of drug of addiction of paraldehyde. These are my references. Thank you.